Ahmed speaking on patient blood management guidelines and the role of MiECC.
Thank you, Mr. Chairman, and thank you for inviting me to speak. We've heard a little bit about patient blood management in a generic sense about cardiac surgery, but what I'm going to do is take you to some of the recent guidelines. So in the last 3 or 4 years, there have been 3 major guidelines that have been published. There have been the European Society of Anaesthesia guidelines on perioperative bleeding management. There have been the EACTA and EACS guidelines that we saw a little bit about yesterday, and the very newest ones are the EACS and EACTA EBCP guidelines on bypass as well, which we just published this year. So what I'm going to do is really just talk about why we're here. Well, it's all about patient quality of care and why are we trying to improve things, because there's a pressure on costs, and there's a pressure on the recognition that transfusions are not very good for people. And within MiECC, why are we trying to do this? We're trying to reduce and improve quality of care. So this is the definition of, from the Society of Blood Management, Advancement of Blood Management, of what patient blood management is. And as we've heard several times, we've been talking about this, and there are different ways of approaching the problem. So broadly speaking, we've seen the 3 pillars, and this is how they work. And in Ekaterina's talk, we just saw that there is anemia screening and getting the patient prepped properly and appropriately for surgery before we come to theatre. Then there's the aspects of what we do actually in the operating room itself. You can do lots of things. You can do cell salvage. You can think about antifibrinolytic agents, meticulous surgery, and similarly at the end, how we optimize hemodynamics, how we optimize oxygenation, and have a low threshold for low hemoglobin for threshold for transfusion. So if we look at this in a little bit, what I want to just focus on is the things in italics. So in the middle section, if you have a look, we're talking about minimizing iatrogenic blood loss, and this is where MiECC particularly comes in, and procedure planning. So we should be thinking about using specific extracorporeal circuits for our patients for specific types of surgery, and the planning of this comes in at the beginning of the surgery before we even think about getting there. Similarly, post-operatively, appropriate blood conservation techniques. We talked a little bit about yesterday about the ultra-rapid anesthesia and wake-up time and getting the relatives involved, and how to optimize these patients' post-operative care as well. Similarly, during the operating theatre, the most important thing is blood-sparing techniques, surgical techniques, and anaesthetic blood conservation strategies. Again, I'll talk a little bit about these shortly. And again, at the end, what we're talking about is minimizing the amount of blood loss. What we don't want to be doing is transfusing these patients and then hemodiluting them and then transfusing them again because the hemoglobin's gone down in relation to where we started from. So there are lots of different examples of good quality techniques that we can apply for patient blood management, ranging from continuous hemoglobin monitoring to pulse pressure variability and non-invasive mechanisms for measuring hemodynamics, depth of anesthesia monitoring, near-infrared spectroscopy for looking at end organ perfusion, and minimally invasive extracorporeal circulation itself. I'm just going to talk briefly a little bit about the Icu usage. You know, cardiac surgery is one of the most common surgeries, and it's a big user of red cells. And about half of these patients require transfusion, and of the patients who've had cardiac surgery previously, more are likely to experience bleeding. So bleeding is a real problem in what we do in ICU. There are multivariate predictors for transfusion, and as you can see in this, there are different aspects of the patient's preoperative condition that can affect how likely you are to require a transfusion. I don't have time to go into them in detail, but as you can see, there are essentially premorbid status is very, very important. However, there are 2 major things. The bleeding in cardiac surgery is important, and in spite of our blood management, a proportion of our patients are still getting large amounts of red cell transfusions. And also transfusion itself is a problem, that in spite of our best surgical techniques and our best anesthetics, cell salvage techniques, our patients are still getting transfused. And so transfusion is a risk factor on its own for perioperative morbidity and mortality. And as you can see, each time you transfuse somebody, the risks of renal impairment, prolonged intubation, longer stay in ICU go up further. So transfusion generally is a bad thing unless your rate of loss is greater than what you're expecting. So there are risks associated with re-exploring a patient as well. So if they're persistently bleeding, you need to bring them back to theatre. But if you bring them back to theatre, you're going to need to transfuse them even further. And those who've had dual antiplatelet therapy are likely to bleed more. And similarly, the mortality goes up every time you bring a patient back to theatre. So re-exploration is not good for the patient either. As you can see here, the more red cells that are transfused, the greater the risk of mortality. If you reoperate on the patient, again, the risk of mortality goes up. And similarly here, the risks of morbidity go up the more you are transfused in terms of red cells. And this just shows you that the 30-day mortality on the left-hand side and the 1-year mortality on the right-hand side, with or without transfusion, shows that generally speaking, if you can avoid a transfusion, it's best to try and avoid it. So the role of guidelines, there have been some recent guidelines that came in. I was fortunate enough to be involved with the European Society of Anaesthesia ones and the EACT ones we talked a little bit about yesterday. And what they talk about is a greater emphasis on volume measurements. They talk about clinical patient pathways and improving enhanced postoperative recovery programs. You're going to hear about that a bit later on. And similarly, the values of trend monitoring, continuous hemoglobin monitoring, to pick up signs of danger earlier rather than later. They also talk about thinking about what's happening in terms of the science, so thinking about factor-based goal-directed therapy and trying to use viscoelastic testing to try and guide your transfusion. And what we recommended, these are the main recommendations from the European Society guidelines that they recommend we use intervention algorithms and think about using viscoelastic testing to guide that. If you haven't got viscoelastic testing, you should apply an algorithm to try and treat the patient, and you should try and use viscoelastic testing if you can with specific triggers. We found that the withdrawal of aspirin increases the risk of coronary thrombosis, but in continuing aspirin also increases the risk of bleeding. Similarly, the same thing with P2Y12 inhibitors like clopidogrel. If you stop clopidogrel early, you've got the risk of transfusion of thrombosis, but if you stop it late, you've got the risk of bleeding. So we do talk about using antifibrinolytics, and there's a good strong evidence for using antifibrinolytics early. And in complex cardiovascular surgery, we should be thinking about using viscoelastic testing all the way through to monitor the patient and to guide our therapy. And this was what we were saying earlier on. So it's a 1B recommendation that viscoelastic testing is useful. Similarly, the more recent ones which have come out specifically for cardiac surgery, we'll talk about, for the first time in the guidelines, the use of minimizing hemodilution and the use of minimally invasive extracorporeal circuits, and how we should think about using smaller amounts of prime to stop the hemodilution. So for the first time here, you can see as an intraoperative recommendation, MiECC is being suggested as something we should all be thinking about for our patients. And similarly here, MiECC systems should be considered over standard bypass systems to reduce perioperative transfusions. So it's something that we should now be thinking about in a bit more detail. And we heard a little bit about the complexity of the circuits yesterday and the different types of circuits. And what we do need to do is perhaps improve familiarity with the circuits, with the system, and with the whole process to try and get this more involved. And as again you saw yesterday, the more minimally invasive heart surgery that is being done, the more likely you are to think about MiECC systems as well to reduce transfusion needs. I just wanted to say a little bit about transfusion of fibrinogen and PCCs, prothrombin complex concentrates. I'm not going to go through all of these in detail, but the important things to think about are that antifibrinolytic therapy has been proven to be very, very useful and shown to be beneficial in patients. None of the recommendations in any of the guidelines suggest that we should be using prophylactically FFP or platelets. So we don't think we should be using them unless you've got clinical bleeding. So the important message is don't give products unless your patient is bleeding. And also don't give products even if the test is abnormal, provided your patient is not bleeding. You must always treat the patient and not the test. Because sometimes you get an abnormal test result, but the patient's not bleeding, you shouldn't be transfusing those people. Similarly, you can see that the use of prothrombin complex concentrates and FFP is becoming more and more important. And the reason for that is there is a proportion of patients, particularly with low ejection fractions, particularly those who have got right ventricular failure, who can't tolerate a large volume load, but they still need to have a high concentration of factor therapy given to them. So these groups of patients are unable to tolerate 2, 3, 4 units of fresh frozen plasma and cryoprecipitate and platelets because of the volume load that they get. This group of patients needs to have prothrombin complex concentrates given to them instead to try and deliver a small volume but high dose of factor therapy. Similarly, fibrinogen therapy prophylactically is not recommended, but if you've got a low fibrinogen post-bypass that has been demonstrated using either a FibTem or a functional fibrinogen test, then we should think about transfusing the patients either with fibrinogen concentrate or, in those countries that have got cryoprecipitate available, a couple of units of cryo as well. And finally, towards the end, prophylaxis of DDAVP is not recommended, but if you do have acquired von Willebrand's factor deficiency, it's worth thinking about if you can demonstrate it. And so the take-home message is don't treat things prophylactically, treat the patient, not the test, and treat things appropriately should you need to. And this is just a summary of what we just said, that prothrombin complex may be preferred over fresh frozen plasma. Prophylaxis is not an ideal, but if you find a low concentration of either fibrinogen or platelets, then substitution may be considered. However, not everybody has found that viscoelastic tests are beneficial. There are some meta-analyses that have looked at things suggesting that in certain aspects, viscoelastic tests, like any other tests, are not 100% accurate. They are used to guide your therapy. They're not a black and white answer of telling you what to do. So looking at this, there were 1 or 2 studies that suggested that thromboembolic events and surgical re-exploration are reduced by using viscoelastic tests, but others have found that they're not particularly beneficial. They don't reduce mortality. They don't reduce reoperation for bleeding, but they do result in reductions of red cell transfusion and platelet transfusions. So again, what you need to think about is that if it's very difficult, like we talked about yesterday, to demonstrate, unless you've got very large numbers, that a specific outcome has changed. However, you can see here that being guided by these tests, you can still result in reductions in red cell transfusions and platelet transfusions, and we already know that these things are independent risk factors for mortality themselves. So EACT's recommendations there is that preoperative testing to predict bleeding is not recommended, but you should think about it should you have a patient bleeding and be guided by the platelet function testing, as you heard from the previous talk. The other thing is that we should be thinking about using MiECC systems to try and reduce the standard conventional bypass circuit blood volume. So these are the most recent guidelines that have just been very recently published, and they suggest that we should be thinking about using centrifugal pumps for longer bypass runs. We should be looking at MiECC circuits. We should be looking at MiECC circuits both for increasing the biocompatibility of extracorporeal circulation and also a combination of the MiECCs in terms of the coating, the centrifugal pump, the whole process should be thought about to improve the quality of the conventional bypass that we're doing. So this is the first time we've come across the evidence base guiding us into the guidelines about thinking about MiECCs. Red cell transfusions and FFP transfusions, I just want to briefly mention, we talked about here, it's clear that if you're very anemic, you need to be given red cells. If you're only a little bit anemic, you need to think about oxygen delivery and tissue oxygenation before you start transfusing, and you should not transfuse people on bypass if their hematocrit's over 24%. Similarly, you should not be giving fresh frozen plasma to people unless you can demonstrate that there's a genuine antithrombin deficiency or you've got heparin resistance. And similarly, if antithrombin is unavailable, then you should think about giving fresh frozen plasma to patients. So finally, just a couple of words about why we are in this position. Well, clinical practice has changed. Our patients have changed over the years. When I first started in cardiac surgery, we had aprotein available. The patients were relatively straightforward. They had single Lima-2 grafts, and they were quick operations. Nowadays, our cardiology colleagues have picked those patients off, and we're getting much more elderly patient groups with more comorbidities, and those patients are now getting more and more complex. They're on more complex antiplatelet therapies as well. There are several scoring systems for transfusion and bleeding risks, none of which are perfect, otherwise we'd all be using the same one. And we've got to assess the bleeding risk and the transfusion risk of our patients before we bring them to theatre, so that we can liaise with the blood banks in advance and say we're going to need to have additional products available. And so what I want to encourage is a critical approach to thinking about each patient. Each patient is an individual. think about their comorbidities, think about the drugs they're on, think about the nature of the operation you're doing. Is it a repeat operation? How long they've been on anticoagulants and antiplatelet therapies, whether they've got existing kidney dysfunction, previous strokes, and similarly also think about the benefits of massive transfusion and blood loss versus if you're going to use antifibrinolytics like aprocinin or tranexamic acid. And the reason that our patients are different is because they've got inherited coagulation abnormalities. These are the ones that are at high risk for bleeding. They can have low platelet counts before they come to surgery. A group of patients may have platelet dysfunction or may be on antiplatelet therapy. They may be on DOACs or they may be on Jehovah's Witnesses. So this is the group of patients we should really be thinking about as to how to minimize blood loss specifically. So in summary, perioperative bleeding is a significant problem. Allogeneic transfusion is not without risk, and it does have poorer outcomes. And we need to think about better patient blood management, and we should be driven by the guidelines, because the guidelines have reviewed all the evidence base out there to suggest what is good, what is not so beneficial, and what is equivocal. Antifibrinolytics have been shown to be beneficial and useful agents, but there are none without side effects. Some have, so high-dose tranexamic acid has seizure activity. Aprocinin has had problems in the past. So we need to think about risk versus benefit. And finally, think about the case selection and think of use of viscoelastic testing for every case and the use of MiECC as well. Thank you very much indeed.
Excellent. Thank you. I think in the interest of time and continuity, I will save any questions till after the next presentation by Dr. Argiriadou from Thessaloniki, talking